Disease has undergone quite a few changes in the nomenclature. So originally as arrhythmogenic right ventricular dysplasia, because it was thought to be basically part of a congenital heart disease. Now it's termed more as arrhythmogenic right ventricular cardiomyopathy because we know it's a disease of the heart muscle. And there are some thoughts that maybe we should be calling it arrhythmogenic cardiomyopathy because it can actually affect both ventricles and not just the right ventricle. It is often inherited in an autosomal dominant manner with incomplete penetrance, but there are also autosomal recessive forms, and they are associated with cutaneous syndromes as well. For example, in Naxos disease, you can have curly, woolly hair, and also keratoderma affecting the hands and the plantar surfaces of the feet. So, histopathologically, if you have to see a heart under the microscope of a patient with ARVC, the hallmark is that you will have myocardial atrophy, or basically you will have myocyte loss. And there will also be fibrofatty replacement of the myocardium. It's important to note that having fat infiltration alone in the myocardium is not pathognomic of ARVC. And histological findings may be completely absent early in the disease. ARVC often spares the septum, but affects the triangle of dysplasia, which involves the posterior right ventricular free wall, the right ventricular outflow tract, and the apex. This is an image showing the triangle of dysplasia. And histologically, what you will find is basically increased adipocytes and also fibrosis and decreased myocytes. So how does this come about? And this is quite interesting. So there are 5 to 7 common genes, mostly there are 5 common genetic mutations, which are known to cause ARVC. And these mutations encode proteins, which are plakoglobin, plakophilin, desmocollin, desmoplakin, and desmoglein. And these proteins are important components in the desmosome of the cells. So here I have a schematic diagram of a desmosome. And desmosomes are cellular proteins prevalent in tissues exposed to frictional and shear mechanical stress, such as the myocardium. I mean, the heart is always pumping, so the myocardium is definitely under stress, and the epithelium. So this makes one understand why, for example, in the autosomal recessive forms, you have cardiocutaneous expression. And these desmosomes, the importance of them is that they impart mechanical strength and cell-to-cell adhesion. And they interact with the junctional complex and intermediate filaments within the cytoskeleton. So as you can see, the proteins which are affected, you have plakoglobulin here, plakophilin, desmocollin, desmoglein, and desmoplakin here. So they do form part of the desmosome. And what happens is that when you have defects in these proteins, you end up having problems with cell adhesion, with transcription, you'll have problems with apoptosis regulation, and this will lead to myocyte death. And because the myocardium does not regenerate that efficiently, what happens is that you will have replacement by fibrosis and fat in this condition. So ARVC often occurs in adolescence and young adulthood, and it is diagnosed between the ages of 20 and 50 years usually. But there are 10% of patients who might have clinical expression prior to the age of 20 years of age. There's a predilection for males, but keep in mind that late onset ARVC may also occur. Symptoms include palpitations, ventricular arrhythmias, syncope, cardiac arrest, and congestive heart failure. Ventricular arrhythmias are often exercise-related, as shown by an Italian cohort, and it accounts for approximately 20% of sudden cardiac death in young adults and athletes. So when we say that ARVC has many faces, this is what we mean. You can have a subclinical course where it is also described as concealed. The patient will have no symptoms, no structural abnormalities, so you do an echo and you won't find anything, but the patient can actually just present with sudden cardiac death. You can have the classical presentation where the patient will be symptomatic, will have structural changes, and will fulfill diagnostic criteria. You can have advanced ARVC, where you have severe structural progression, dilatation of the right ventricle and of the left ventricle, giving you a picture similar to dilated cardiomyopathy, and this would be like end-stage disease. Then there's another subset of ARVC, which is the left-dominant arrhythmogenic cardiomyopathy, where you can have a patient presenting with ventricular arrhythmia, but of right-funded branch block morphology, as it is coming from the left ventricle, and this would be out of proportion to the degree of left ventricular dysfunction. So they did, the task force of myocardial and pericardial diseases had done diagnostic criteria in 1994, and these have been updated in 2010, and they are based on the following features: structural, histological, arrhythmic, and familial. And to diagnose ARVC, you need to have 2 major criteria, or 1 major and 2 minor, or 4 minor criteria. Now this is taken directly from the article, quite hefty and complex, so I'll be going through it bit by bit. So, performing an echocardiogram, you have to look out for the major criteria, and these are regional or global right ventricular akinesia, dyskinesia, or aneurysm formation in the right ventricle. And you have to have one of the following: an RVOT of more than 32 millimeters on parasternal long axis, or an RVOT of more than or equal to 36 millimeters on parasternal short axis, or having a fractional AR change of less than or equal to 33%. As regards to minor criteria, you should have regional RVA kinesia or dyskinesia without aneurysm formation, and one of the following: the RVOT on the parasternal long axis between 29 to 32 millimeters, and on short axis the RVOT of more than 32 to less than 36, and the fractional area change of more than 33% to less than 40%. These are a few examples of echocardiography in patients with ARVC. So in the first case, the RVOT measures around 30 millimeters, but then you can also measure the RVOT depending on the BSA as well. Here you have then the parasternal short axis, where you have an RVOT measuring 32 millimeters. In this view here, you can see that there is an apical aneurysm of the right ventricle, which is a major criteria for ARVC. Some groups say that if you have increased reveculations in the right ventricle, that might be a sign of ARVC, but it is not in the diagnostic criteria. And also having a hyperreflective moderator band can also give you, could be a feature of ARVC. But again, this is not in diagnostic criteria. A point here is that sometimes having the moderator band here can give you the impression that the RV apex is a bit aneurysmal. So you have to be a bit careful how to interpret it. So this is an echocardiogram of a Maltese patient who, as you can see, the right ventricle is definitely dilated, and also the left ventricle is not functioning that well. His parasternal long axis measures around 34 millimeters, but it was quite enlarged even for his BSA. Here you can see that the moderator band was quite reflective, and you can see that the right ventricle is akinetic and severely dilated. And then on the southwest view, you can also see that the right ventricle is dilated and akinetic, but you can also see there might be some outpouching in the right ventricular free wall next to the apex, which might be an aneurysm. Then there might be an aneurysm component there. Okay, now further structural features. Cardiac MRI, what are the major criteria? It's quite similar to echo, so regional RV akinesia, dyskinesia, or the synchronous RV contraction. And one of the following, a ratio of RV and diastolic volume to BSA of more than 110 mils in males, or more than 100 milliliters in females, or an RV ejection fraction of less than 40%. The minor criteria in MRI are regional RV akinesia or dyskinesia, and one of the following, a ratio of RV and diastolic volume to BSA of more than 100 to 110 mils in males, or more than 90 to less than 100 mils in females, or an RV ejection fraction of more than 40 to less than 45%. A few points on cardiac MRI and the RVC. Cardiac MRI is often challenging, even in a patient with a normal right ventricle, because of the complex geometry and contractility of this ventricle. And sometimes cardiac MRI can actually overestimate ARVC. Do not forget that the cardiac MRI, which is normal, does not exclude ARVC either, because it can be normal in early disease. And late gadolinium enhancement, which is a marker of fibrosis, may be seen in both the right ventricle and also the left ventricle, because you can have left ventricular involvement. So these are a few CMR images. They're of the same patient, and what you can see is that you've got the right ventricle here is definitely dilated. You've got some outpouching over here, which shows aneurysmal formation. This is showing fat infiltration. And here you've got late gadolinium enhancement, which indicates fibrosis around the septum and also the inferior wall of the left ventricle. Then histological features for diagnosing ARVC. It's basically, if you take an endomyocardial biopsy, you ideally should measure how many myocytes there are. They can actually perform morphometric analysis, and if there are less than 60% of residual myocytes or less than 50% on estimation with fibrous replacement of the right ventricular free wall, and that is a major criteria for diagnosis of ARVC, with or without fatty replacement. So as I mentioned earlier, fatty replacement of the tissue alone, without any fibrosis or myocyte atrophy, is not diagnostic of ARVC. And in the minor criteria, it's similar to the major, but there will be more myocytes present. So what about ECG criteria? So the major criteria for ARVC are having T-wave inversions from V1 to V3 or beyond, and this should be in patients more than 14 years of age. The reason being is that a patient who's younger than 14 years, it's normal to have T-wave inversions from V1 to V2 and even V3. So that's why they put this cutoff on the age. And this is in the absence of right bundle branch block, so that's a major criteria. Also, having an epsilon wave on the ECG is also a major criteria for diagnosis of ARVC, as this indicates delayed activation of the right ventricle. Now, what's very, very important is that ECG changes can actually precede any echo change or histological change in ARVC. So the ECG should be scrutinized very, very carefully. So as regards to minor criteria on ECG, if you have inverted T waves in V1 and V2 or beyond in individuals of more than 14 years, or even in V4, V6, in the absence of right bundle branch block, that's a minor criterion. If you have inverted T waves in V1 to V4 in the presence of right bundle branch block, that's a minor criterion. Then they also mention signal average ECG, where basically it's done with the ECG machine, and there's a computer software which basically averages all the signals and therefore decreases the amount of noise. And there are 3 parameters which they look at, which I've listed here. And basically, if these are abnormal, if you have one or more of these abnormal, then that will satisfy a minor criterion. If you have terminal activation duration of the QRS of more than or equal to 55 milliseconds, measured from the nadir of the S wave to the end of the QRS, in the absence of complete right bundle branch block, that's again a minor criterion. Of epsilon waves, okay, and basically it's a positive deflection after the QRS. These are a few examples of the ECGs. This is an ECG of a patient with quite advanced ARVC. It's a patient, and as you can see, the complexes are quite small, and you have T-wave inversions from V1 down to V4. And this is another example, T-wave inversions from V1 but going down to V5, even V6. And if the T-wave inversions are beyond V4, that usually indicates that there's left ventricular involvement as well. This is a Maltese patient who, as you can see, has right bundle branch block, but does have inversions from V1 to V4. On double speed ECG, you could actually see an epsilon wave. Unfortunately, I didn't have it. So what about arrhythmias? What are the major criteria for arrhythmias? So if you have a non-sustained VT or a sustained VT of left bundle branch block morphology with a superior axis, meaning it is negative or indeterminate in the inferior leads, and positive in AVL that means that this is a major criteria for ARVC. You are going to have a left bundle branch block because the VT is coming from the right ventricle. And I have an example here. You can see that it's a left bundle branch block morphology, and it is negative in 2, 3 and AVF, but it is positive in AVF. As regards to minor criteria, a non-sustained VT or sustained VT of RVOT configuration is a minor criteria. No? Sometimes when we say we have RVOT ventricular ectopics, we always think of it as a benign ventricular tachycardia, which it is alone. But then if you have other criteria satisfying the ARVC, then it becomes a minor criteria. So, in this case, the left bundle branch block will be with an inferior axis, and it will be positive in its 2, 3 and AVF, and negative in AVF. Also, performing a 24-hour tape and finding more than 500 ventricular ectopics with the left bundle branch block morphology is a minor criteria as well. So this is an example of an RVOT tachycardia, and you can see that it is positive in 2, 3 and AVF, and negative in AVF. So what about the family history? Major criteria, ARVC, if it's confirmed in a first degree relative by satisfying task force criteria, then that's a major criteria. If the ARVC has been confirmed pathologically in a first degree relative, that's a major criteria. And if the patient himself has a pathogenic mutation which can cause ARVC, then that is also placed as a major criteria. Minor criteria are if there's premature sudden death due to suspected ARVC in a first degree relative less than 25 years of age, and if ARVC has been confirmed in a second degree relative. So ARVC is quite complex even to diagnose, and once you diagnose the ARVC, then we have to see how to manage the patient. So one important thing is to ask the patient to avoid intense exercise. Exercise is known to trigger ventricular arrhythmias, but also because exercise increases the mechanical stress on the heart in the right ventricle. And remember that we are dealing with a desmosomal disease, then this can increase RV dilatation and RV dysfunction. In the first instance, if you have a patient who's symptomatic from his ventricular arrhythmias, you should consider beta blockers, sotalol and noramiodrone. This is obviously depending if the patient is having unstable VT or not. In some centers, catheter ablation can also be performed with electroanatomic mapping techniques. But when they ablate the VT, remember that ARVC is a progressive disease, so if you ablate certain foci, you can actually get other foci giving you VT. So it's not that curative. Having ARVC alone does not mean that this is a knee-jerk reaction to put in an ICD. Okay, so I will go into risk certification in ARVC shortly. Then you can also use diuretics, ACE inhibitors, and beta blockers when you have heart failure. And ultimately, you might need heart transplantation, not only because of a low cardiac output, but also, in some cases, you can have intractable ventricular tachycardia. So the markers which indicate that the patient needs an ARVC is if the patient is having unexplained syncope, if there's aborted sudden cardiac death, and if the patient is having hemodynamically unstable sustained VT. Okay, so if the patient is feeling lightheaded or faints when he's having episodes of VT, then that's definitely an indication for ICD insertion. If you have a patient who's having VT but is completely asymptomatic, in some cases there's no need to actually insert an ICD. So another interesting thing is that in hypertrophic cardiomyopathy, we know that if there's a family history of sudden cardiac death, then that is a risk factor, and one should consider putting in an ICD. Obviously taking into account other risk factors, because you need to have 2 risk factors or more in HCM. But in ARVC, the family history of sudden cardiac death is not thought to be an indication for ICD insertion. And the reason being is that it is thought that patients who die suddenly from ARVC have had more than one genetic mutation, and it is quite unlikely that in a family that there is more than one family member to have 2 genetic mutations causing this disease. Markers of poor prognosis are if the patient has been diagnosed with ARVC at less than 35 years of age, if there's a prior cardiac arrest, if there's poorly tolerated PT with different morphologies, if there's a history of syncope, severe right ventricular dysfunction, left ventricular involvement, and the family occurrence of sudden cardiac death. There are certain conditions which actually make ARVC, either from an arrhythmic point of view, like RVOT ventricular tachycardia, Brugada syndrome, CPVT. You might think that from a structural point of view, if you have a right ventricular infarction, Einstein's anomaly, right ventricular overload secondary to congenital heart disease may also mimic ARVC. And then there are cases like sarcoidosis, viral giant cell myocarditis, which are quite arrhythmogenic, can mimic ARVC. And then, as regards to fatty infiltration of the myocardium, if someone is an alcoholic or suffers from Duchenne's or Becker's muscular dystrophy, there can be fatty infiltration of the myocardium. As regards to, you have to look for T-wave inversions, B1 to B3 over 14 years of age, late potentials on signal average ECG, VT of left branch morphology. They do mention 200 ventricular ectopics or more of left bundle branch morphology, mild local dilatation or RV regional hypomagnesia, and it's important that ECG and echo on the Holter should be performed every year on these first-degree relatives. So ARVC is a complex disease, and 30 to 50% of cases are typically transmitted as autosomal dominant, and there's marked intrafamilial phenotype diversity. You can have a relative who has died suddenly because of ARVC, and then you can have another family member who just has around 1,000 ventricular ectopics on the Holter and minor ECG changes. So it is thought that environmental modifiers play a role. There's also a gene dose effect on the phenotype, so the more genetic mutations you have, the worse your phenotype. And I think it's important to take home that ECG changes may actually precede structural changes, and therefore scrutinization of this ECG is very important. Thank you.
Thank you, Luciano. A very British presentation, very clear, straight to the point. Even dress code is very British, I think. So, discussion. T-wave inversion V1 to V4. It's something which we come across quite often in our patients. We do an echo, normal, which we follow them up. Echoes remain normal. And yet it's one of the major criteria for epileptical dysplasia.
So, I mean, it's important to look for it and to keep monitoring these conditions. I mean, in the UK, they have an abnormal ECG, we used to follow them up. If you have someone who's having a lot of...
So just an abnormal ECG with no family history, no...
Because remember that they could start off the disease. So, I mean, in the UK, they were very, very, paranoid, if you want to put it like that. But, I mean, even if you have someone who has a lot of ventricular ectopics on board, you still used to see the patient every year. And assess for syncope, assess for any malignant symptoms.
And repeat that goal for MRI.
Not MRI. MRI is important, but as you can see, I think the important thing is also performing an echo. An echo and an MRI are quite good, both of them really. MRI will show you the fibrosis, which you won't see on echocardiography.
These changes so often that
yes, you see. You have to take it in context as well. That people are known to have ST. Yes, even at least.
You show that what is ECG to me more than a Brugada than ST elevation, right on the ground floor.
Yeah, that's why they can mimic. And interestingly, they have found that some cases of ARVC actually have the genetic mutation which is found in Brugada. So there's a lot of overlap as well. But that's why they've done these.
I have two patients, and they're both British. They were both based in the UK.
Okay.
If you tell them, one of them was a professional footballer. He made the UK team.
And he's got a those are very
Also, I think in Italy, no, they found there's ARVCs in their center patients,
yes.
as opposed to in America they have the Hoke.
Exactly. So, for example, in Italy, they quote the incidence from 1 in 1,000 Colorado. So they,
In athletes,
yes.
by ECG, no, they
And they usually, I mean, they screen their athletes.
with echoes as well.
Yes, that goes as well.
While some countries just they advise just an ECG, and then if the ECG abnormal, you can go for an echo. And the main problem is the workload. That's the problem. Sometimes the patients have some minor errors on the ECG, do an echo, it's normal. That's all. I mean, you reassure him.
I mean, that's one of the things which
But the problem is
impressed me when I was there. I mean,
the problem is the workload. I mean,
following up a patient who has, quite a lot of ventricular ectopics.
200 there, you said that's more metropolitan.
Yes. And this is, I'm quoting from the task force criteria. I know.
because you would be seeing 1,000 patients every year who maybe avoid a certain death if you, I don't know if you would avoid it in the end, because if they come to when they have symptoms, then you just warn them, listen, if you have symptoms, come back. That's the what I do. If you listen, I didn't find anything. If you have any symptoms like dizziness, etc., please come back. So that's the dilemma.
No, I mean, that's the thing. I mean, when I saw that in the UK, I was quite impressed for the amount of patients that sometimes you're following them up year after year and you realize that they haven't found anything yet.
And they're followed up by a tertiary center? Or?
So we start clinic every Friday, just ARVC screening and ARVC patients.
Because like you told me as well that you follow up all admissions with myocarditis. That for us it would be another a couple of 100 patients a year. And
their reasoning is that they can develop DCS.
Yes. But imagine.
I know, I mean,
obviously that's a skewed perspective because that's a tertiary center and those people do just that. So it was the same with me when I was doing that specialty.
But if we have 200 patients a year or even more with myocarditis, then following them up at a journal would have 2,000, 3,000, 4,000 patients for just saying hello every year to them.
Is this happening to the other 60 million liaison in Inglaterra?
Or they just
the ones that come that are picked up probably and are referred to a tertiary center.
But
how many non-tertiary centers would refer their myocarditis to a tertiary center?
I guess it depends on who sees you.
To
get referred to a tertiary.
If you're in one of these villages in the middle of the countryside,
They wouldn't even
but there is always, but I mean, it depends on who sees you in the district general hospital and whether they know they should refer you, because you can't just pitch up one day and say,
but if we can get 200 a year, then you should get hundreds of thousands in the UK. And I doubt that.
From what I remember, was patients that were admitted at the heart originally with myocarditis. That's how they.
So, Tiziana, if you're screening an athlete, professional footballer, and he is asymptomatic, and you find T-wave inversion V1 to V4, his echo is normal. Does that mean he cannot play competitive football just because of T-wave inversion V1 to V4?
I mean, that's always a bit tricky.
Just a minor criteria, no? It's a minor criteria.
It is a minor criteria.
It's a major plug.
Sorry, wait. Without complete right bundle branch block, then it's a major criteria. So in that case, you have one major criteria. It still doesn't fulfill diagnosis of the ARVC, but it definitely keep an eye on him. And I would.
Answering your question, as far as I know, in athletes, particularly athletes, especially black athletes,
You can't have.
the T-wave inversions before V6 is taken rather lightly. They're followed up, but taken rather lightly and allowed to play. But if it's V1 to V4 or V1 to V3, then you have to follow them up much more closely and you have to be very cautious. Whether to stop them from their sport, that I don't know.
It's very hard. And then the other.
I think the Italians, part came out with those criteria regarding athletes.
When it comes to echoes, thing is, I'm looking at the right ventricle, look at the cavity. If the cavity is wide and dilated, then if it is a small cavity, then this right ventricular curve will be put on WH, which is what puts the effect in that key.
But then the other thing is, don't forget that athletes sometimes have a dilated right ventricle normally. So it is quite tricky.
If you play a key now,
One of them. Why is it because it's a genetic problem? Why does it affect the right ventricle?
They don't know. They don't even know why it affects that particular area. The right ventricular outflow tract, the apex.
probably because it stretches a lot, it dilates.
It's thinner.
It's thinner. And a second, I mean, if you put a transplantation in a patient who is genetically predisposed, this new heart is going to be affected as well eventually. No? No?
No, because it's within the heart, the genetic. No?
But don't we replace the myocytes and don't we replace our cells all the time? What my question is, does a genetic disease affect the recipient organ?
No.
It doesn't.
No.
I don't know. It's a
No.
Because the storage disorder, yes, the storage disorder.
Storage disorder, yes. The problem is not in the heart alone, it's the position.
So this is a problem in the heart alone?
Yeah.
It's in the heart muscle.
Excellent. Just a reminder, this is